Hi, my name is Colina, and on behalf of the COVID-19 nurse study team, I first would like to thank the planning committee to give us this opportunity to present the study today. And I'm going to start off with the introduction. I would like to share with you the concept development and tell you why we want to do the study and how we do the study. So as we all know, COVID-19 pandemic has really caused an unprecedented time of fear, social isolation, and social distancing to many of us across the globe. And because of the many restrictions and regulations, and this pandemic has created a very difficult time for all of us worldwide to deliver our normal patient cares and to meet our patients' care needs. Ironically, 2020 has been landmarked as the International Year of the Nurse. Yes, we should be celebrating and our work, but our work during the pandemic has changed so much, and it's really making a new chapter in the nursing history. And majority of the time we hear on the news like the nurses heroes, they are from the intensive care, they're from ER, critical care, but it actually affects all of us, all the nurses in all disciplines. So how about us in hepatology? As we all know, we are very important in providing direct care to all our patients with liver disease, in particularly hepatitis C treatment. So the questions that as a few of us were chatting, and we want to find out what are the challenges faced by us when there's so many disruptions to our normal healthcare delivery. And these are all unknown to us. Each one of us have our challenges, but we really need to get together and we want to highlight these challenges, and we want to have a little history in our hepatology nursing. So we put forward this idea to CAHN, to Donna, the president, and we have her full blessing and her full support to proceed with the study. So the study aim is to gain insight as well as to reflect COVID-19 impact on us and on our clinical practices. So basically, there are two research questions. The first one is, in what way has COVID-19 pandemic impacted our nursing care practices? And the second question is, what are the strategies we've employed in dealing with the well-being of our patients, not only our patients, but of ourselves as well? And the study design is very straightforward and simple. It's an online questionnaire survey. I call this a hybrid survey because it consists of both quantitative and qualitative questions. And the intended participants are CAHN members. And I'll explain later on my next slide why I say intended participants, because we have made a little error on our distribution list. So the invitation to participate was sent by emails and then later on was posted on the social media. The participation is totally voluntary, and the participants have the choice to receive a $20 gift certificate as compensation of their time spent on the survey. And this study was approved by the Nova Scotia Health Authority Ethics Board, and thanks to one of our team members, Sarah, from Nova Scotia, who has spent many hours in doing all the tedious ethics board submission work. So as you can see here, the study timeline, we actually have a very short time frame to have the study completed. The concept of the study was conceived around April and May, and we had our first ethics submission in June. And there were a little mistakes, and we're learning our mistakes, and there's some grammars that we have to correct on the proposal and so forth. So that was the first amendment made in July. And we sent out an email blast as our first invitation in July. And that is where our first little error was made. Instead of sending only to CAHN active members, we send out to both CAHN members and non-members. And how we rectify that is we send an ethics amendment and telling them what we have done, and then all the subsequent email blasts were intended to only CAHN members. And the third amendment submission was in August. The intention was mainly because the participation rate was a little under expectation. So instead of a third email blast, we included the posting on the social media. So just in terms of the survey, there are 3 parts to the survey. The first part is on demographics. It's the usual questions about the participants' age, the position, and the practice settings. And the second part is on the quantitative questions. And we're asking questions about impact on clinical care and the impact on the other aspects of nurses' life. And the final part of the survey is on qualitative questions. Now, participants have the choice that they can omit and not answer the qualitative part of the survey, but we do encourage them to participate and write down their thoughts. We encourage them to describe their thoughts as detailed as possible. So I'm going to invite my colleague Leslie, to describe to you the quantitative analysis result.
Hello. All right, so now I'm going to talk about the quantitative results. So first of all, I'm going to talk about the demographics. So we had about a 32% response rate amongst those that we consider to be active members. And the majority of the cohort we uncovered was that they were about either between the ages of 30 to 40, so that's about 37%, or over 50 years old, so about 39%. A majority of them had identified themselves as RNs, so about 83%. We also had 2 nurse practitioners, so about 5%, and we also had about 10% identify themselves as LPNs or RPNs, so registered practical nurses. Approximately 64% of those that responded work in community health centers or clinics, and about 17% work in hospitals, and about 75% identified their primary nursing role to be in viral hepatitis, specifically in hepatitis C. Interestingly, about 41% of those that responded identified to have between 0 to 5 years of experience in hepatology, and 41% had about 6 to 15 years of experience. Interestingly, there were no responders with over 25 years of experience, although I do know that they do exist out there. Colina, who's nodding, definitely is one of those, but there are definitely some other colleagues as well with over 25 years of experience that we know. And it would have been very valuable to also get their insights, but be interesting to be able to debrief that at another time. So the next thing that we looked at was in terms of the impact to the practice setting, and overwhelming majority, so about 91%, have reported moderate to extreme impact on nursing care delivery. About half of them had deemed that their workplace staffing issues were not applicable. Unfortunately, we were not able to tease out why that was the case. We're not sure if it's because a number of our nurses that had responded are independent contract workers. That part is unclear. In that, about 56% of the individuals had identified that their practice settings had temporarily closed, and another 54% had their normal duties reassigned, although we were not able to identify what type of reassignment they ended up in. Reassuringly, 88% of the individuals that responded did feel that their workplaces took good safety precautions against COVID-19. And the question then is how does that impact then the clinical practice? And so, it was interesting to hear from the response in regards to this. So first of all, was looking at even amongst the nurses who had known of someone who had tested COVID positive. And so amongst patients, about a fifth of the nurses had reported that they had known positive cases, and that was in Saskatchewan and Alberta. Amongst members, 2% reported a positive COVID-19 test, while 8% reported that they had known a positive case within their workplace. These next statistics are, I think, very relevant, especially in relating to clinical practice and management of viral hepatitis and cirrhosis management. So 63% have reported Hep C testing interruptions during the pandemic. And as such, about almost 70% had reported delays with Hep C treatment initiation. Amongst the individuals that had responded, almost a half of them did not know if their patients had developed disease-related complications. This part we hope could be teased out a little bit further. We were not too clear about why they did not know, and we're not too sure if it was because of limitations of not being able to contact their patients during the pandemic. But what we do know from the individuals that responded in terms of cirrhosis management, there was significant impact, with over 71% of individuals reporting that there was some interruption to HCC surveillance, and almost 70% had reported there was also interruptions to varicose surveillance. The last important piece that was looked at in terms of quantitative, the quantitative part of the study, was looking at overall impact to other aspects of nurses' lives. And so in that, we thought that it was important to look at this piece because I think this speaks to a lot of the other aspects that we do appreciate as being impactful individually for each of our nurses during the pandemic. And so first, we looked at their total number of hours worked, and about 17% had reported working less hours. About 54% had reported no change in the working schedule. In terms of their way of delivering their care, a number of them did report changes. About 8% went totally remote. Another 39% reported more of a hybrid setup for remote work. And in this, 56% reported no competing commitment for time with work from home. And this is an interesting piece to tease out, although it wasn't gleaned in this way, why there was no competing time commitment for work from home. And about 56% still reported that they were not working from home at all. In terms of fear for self and family, about 59% reported moderate to severe levels of stress in personal lives, and about 22% reported extreme levels of stress. Reassuringly in this, a majority of individuals, so more than 3/4, reported minimal impact on financials thus far, and that is reassuring in that sense, but keeping in mind that over a majority of our members that had responded had spoken about some type of redeployment to a different work setting at this time. And so now I'm going to allow for Leslie to take over, and where she's going to talk about the qualitative results.
Thank you, Liz. Hello, I'm Leslie Gallagher, a member of the COVID-19 nurse study team. The 7 qualitative questions in the survey were answered by 29 of the respondents. Many work in community settings, as previously mentioned. By nature, narrative statements are more difficult to analyze. The methodology used for this qualitative analysis is known as a constant comparative analysis. All of the survey responses were collated into bullet points according to their main topic ideas. Numbers of respondents with similar responses were documented. We took one statement, one response, and one theme, comparing it to all others, both similar and different. We analyzed, interpreted, and now I will present the findings. There are 6 themes identified, and I'm giving examples of the nurses' responses along with each one. Insecurities. Nurses voiced concern over shifting priorities in the workplace and the deployment of resources. But their main concern was the impact that these changes were having on the vulnerable patients living in the communities where they practice. Lack of funding has limited access to shelters and to food. Restrictions in place due to infection prevention and control measures have forced shutdowns. Bathroom facilities in the inner cities have closed. Transportation is no longer available or not permitted under new guidelines. Patients are moving to encampments or being displaced to hotels in unfamiliar neighborhoods. Enforced isolation during an opioid crisis with a toxic drug supply has resulted in increased overdoses and deaths. Patients are now prioritizing their basic needs for survival, and as a result, nurses are observing a lack of engagement by their patients. Limitations to healthcare. This theme compiled the highest number of responses and highlights how hepatitis C care and treatment has been impacted. Resources deployed to COVID-19 screening and testing directly impacted hepatitis C lab testing. Hepatitis C RNA and genotype testing was suspended for more than 2 months. Laboratories were closed or offered restricted hours. Clinics were closed to anything non-essential with reduced open hours. Hepatitis C intakes were considered non-essential. Clinics closed to new patient referrals. Group teaching and group therapy was terminated. No face-to-face appointments were permitted. Prescribers were unavailable or worked reduced hours. Therefore, hepatitis C treatment starts were on hold or decreased. Staff was deployed. With reduced staff to support patients in community, lack of engagement with patients by healthcare providers occurred. Now, in the previous slide, I mentioned that there was a reduced amount of engagement by the patients themselves. They had pulled back and they were focusing on other issues. But now we see that it is also the healthcare providers are disengaging, and this is due to a shortage of staff. So we're being hit here with a double whammy. Also, longer wait lists for specialists were observed, and as mentioned by Liz, surveillance for hepatocellular carcinoma was postponed or delayed. Initial lack of PPE was mentioned more than once. Clinics closed as staff tested positive for COVID-19. But nurses did observe some positive outcomes within the limitations. Steps were eliminated for hepatitis C pre-treatment investigations and on-treatment monitoring. Therefore, a simplified Hep C treatment plan was adopted in clinics. A more efficient flow was seen in the clinic while following the infection prevention and control guidelines. Fear of COVID-19 is a broad theme which impacts us all. The fear of contracting COVID-19 within the community or in the healthcare environment limited patients accessing any form of healthcare. COVID-19 screening and triaging prior to permitting entry to clinics can be a deterrent. Walk-ins were no longer permitted. Patients were seen by appointment only. Limited numbers of patients were allowed to be present within a facility at any one time. Increased use of PPE in clinics and during outreach appointments to patients in housing or shelters was used, and therefore a fear of lack of PPE was mentioned again more than once. Teaching component with patients now includes reassurances to safely venture into community and attend appointments. Nurses are reinforcing the new rules and giving permission. It was observed that contact tracing can be difficult as patients are transient and do not always use their real names. Nurses expressed fear of bringing home COVID-19 to families, which may include immune-compromised loved ones. Nurses expressed stress over childcare concerns and negotiating with employers who may not be sympathetic to the need for creative scheduling. Telephones. This device became a theme all on its own because it was frequently mentioned as a strategy to maintain therapeutic communication. Telephone appointments have allowed improved access to patients, especially in rural areas. Clinics are providing telephones on site for patients to connect with healthcare providers who are reluctant or refusing face-to-face contact. Phones have enabled nurses to continue providing care while working from home when their employers permit. However, it is noted that telephone appointments do not allow for personal interaction, making it difficult to assess stability and hepatitis C treatment readiness. And it was acknowledged that telephones are not accessible to everyone in the patient population, and this does present barriers. Outreach. Outreach is crucial to engaging patients into care. Because of restrictions within clinics, nursing care is being increasingly performed through outreach and in outdoor settings. It was noted that there is difficulty finding patients due to relocation. One nurse mentioned that more time is now being spent driving and searching. There are fewer healthcare providers and support staff available to outreach patients. Support staff are restricted from driving patients to appointments and to labs. Medication appointment referrals and reminders and lab recs are often dropped off through outreach or delivered by Canada Post. And the final theme is collaborations. A very big shout out was given to pharmacists by several of the respondents. Nurses were appreciative of their multidisciplinary team members. Pharmacists were repeatedly mentioned as a key touch point between patients and their healthcare providers. Nurses are relying on connections with pharmacists for med initiation, med dispensing, med delivery, med adherence, and messaging. IT departments are providing tools for virtual visits within clinics and virtual telehealth from distance. One nurse stated that the FibroScan was relocated from the tertiary center to the clinic to decrease possible exposure to COVID-19. The physician also moved his practice out of the acute care facility and into the clinic. Another nurse observed that recruitment into clinical trials had increased due to loss of income and the ability to now access medications without cost through study means. So here's a recap of the 6 themes that we identified. And I would now like to invite Anna to present the summary and concluding remarks. Thank you.
Thank you, Leslie. Hello, everyone. My name is Anna de Wolf. You have now heard the quantitative and qualitative results. For the conclusion, I have taken reflections from each of our project team members, so I freely admit to paraphrasing many of their comments, and I've posed questions as to how CAHN as an organization can continue supporting our members and hopefully affect changes if necessary. The aim of this study was to gain insights and to reflect how the COVID-19 global pandemic has impacted our hepatology nurses and their clinical practices. We all acknowledge this research project captured an unprecedented moment in time. It brought visibility and voice to the work hepatology nurses do and the challenges and constraints they have faced within this pandemic, often working with patients already socially and monetarily disadvantaged. The results highlighted the tremendous flexibility of nurses to change their duties, their dedication to adapt to their practice settings, and their ability to quickly facilitate policy changes when a state of emergency occurs. As you have heard in the quantitative presentation, 91% of respondents reported an impact on delivery of nursing care. A large majority of the respondents were community-based, providing hepatology care outside of the hospital setting. Nurses reported difficulty connecting with patients and the inability to meet many patients' needs. This in turn resulted in fewer numbers of patients accessing procedures, and subsequently HCV treatments were delayed or postponed. Patients' priorities definitely shifted. Nurses were redeployed and patients displaced, which changed the healthcare environment within many communities. Nurses frequently identified the need for more dedicated resources for our hepatology population who are housing and income insecure. The pandemic showed there is no buffer. Programs often run on low budgets, and subsequently, our hepatitis C patient population was deeply impacted. Resource gaps need to be identified and brought forward to decision makers. When consequences to healthcare are named, this can be used to advocate change. If we do not call it out, then who will? This has great potential for CAHN to become actively involved, not only at a system and organizational level, but also politically, advocating for our patients locally, provincially, and federally. Creative solutions were provided by the respondents, showing their depth of knowledge of the patient population and their deep commitment to make viable changes. Collaboration with our community partners, especially pharmacists and outreach communities, was front and center to many strategies employed. Based on the study results, the implications for CAHN are potentially huge. But we also do need to be realistic in what we can facilitate and accomplish as an organization. According to the study, financial stress to nurses was not a concern, but fear and increased personal stress were identified by both patients and nurses. How can CAHN further support our members? In order to help alleviate their own stress and/or work challenges, it is probably advisable for nurses to continue networking despite COVID isolation. And this virtual conference is a great example of a platform created out of the need to maintain communication between colleagues during this pandemic. Nurses are primarily concerned about their patients during this time. Observations of HCV surveillance being deferred and postponed past the best practice of every 6 months were identified. But this is not necessarily a nursing role. It is an observation that delays are occurring at healthcare facility organizational levels. Therefore, how can we as nurses best support our patients diagnosed with advanced cirrhosis who require more vigilance? Continuing education for our members is an important mandate of our organization. Our demographics have shifted, with many members having less than 5 years of experience. This data within the study, although not necessarily a conclusion from responses, does highlight the need for CAHN to continue supporting educational opportunities to promote excellence in clinical practice. Supporting research is one of CAHN's core values. The study project team members thoroughly enjoyed coming up with a framework for the study and were quite excited to hear the results. We truly appreciated all the participants taking the time to respond. I mean, obviously it goes without saying that without you, the study wouldn't have been possible. The quantitative data offer great insight, and the qualitative narratives submitted were detailed, thoughtful, and at times almost humbling to read. On a personal note, when I read through the detailed responses to the question addressing our marginalized populations, I found myself gradually becoming quite overwhelmed with a tremendous sadness. You know, how has society allowed such a large proportion of people, human beings, to become so basically uncared for by the general population? It's seemingly unimportant. So why are community nurses, social workers, support service workers, all these amazing professionals who work regularly with marginalized people, why are they having to assist so many of our country's citizens just meet their basic needs? It's a loaded question. So remote isolation can be felt anywhere by anyone and at any time. Hepatology nurses care for some of our most vulnerable citizens, helping keep them safe and healthy. The study project members, thank you all for your amazing dedication to your profession and your patients. We know you face many added stresses, both professionally and in your personal lives. So please look after yourselves, continue following all those necessary precautions, stay safe, and above all, healthy. And thank you once again for all your valuable contributions to this study.